Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, we have another fantastic show for you today. And before we get into the meat of our show, I would like to talk about caring and sharing. Remember, I enjoy those emails and those tweets so much. www.medmoments.com and tweet me at medmoments. Believe me, our health is the most important thing that we have. Come together, tweet me, email me, let me know what's going on out there so we can improve our show so that you can be more knowledgeable about your health. Well, we have a great topic. Our topic is cardiothoracic surgery, and I have the perfect person to cover this topic. He's Dr. Robbie Karanam. He's a cardiothoracic surgeon at Newark Beth Israel Medical Center. Dr. Karanam, welcome to our show.
Thank you, Omar. Pleasure to be here.
All righty. This is very, very important, this topic, because I understand that each of us get old, and we all will have some heart disease at some point in life. And so I think that this is a topic that needs to be covered. And let's just get started. Because we have a lot to cover. To cover.
Let's go.
So what is cardiac surgery, I should say?
It's a surgery of the heart.
Mm-hmm.
Cardio is heart. Surgery that's done on the heart is cardiac surgery.
Mm-hmm.
It's part of a discipline called cardiothoracic surgery, where the surgeons operate in the chest, from root of the neck to the pit of the stomach, all the organs involved. Heart happens to be one of the principal organs that's encased in that.
Mm-hmm.
So the surgery that's done on the heart is called cardiac surgery.
Excellent. Now, why would somebody need such surgery? I mean, what happens to their heart that it would need surgery?
Well, we're all endowed with the fortune of good health,
mm-hmm.
but for one reason or the other,
mm-hmm.
either because of people's misbehavior or genes, in course of time, heart begins to suffer from one illness or the other. The common one is coronary artery disease.
Mm-hmm.
But despite all the best attempts of taking care of good health, doing everything right, physician taking care of you, there comes a point you reached up at a crucial moment in life that you need a second lease on life, because if you do nothing, you'll get a massive heart attack, heart failure, something. Mm-hmm. Your life will be shortened. In order to prevent that, heart surgery comes in at that time as a rescue for those patients.
Okay. I just want to get an understanding. You said a word, coronary artery disease. What is that?
It's atherosclerosis of the arteries that supply blood to the heart.
Okay, you're going to have to explain atherosclerosis.
Yeah.
I like that.
Atherosclerosis is basically hardening of the arteries.
Okay.
How does it happen? It's principally because of cholesterol built up in these arteries. Arteries are blood vessels that carry blood to the organs, including the heart, and that blood carries the nutrition and oxygen to the tissues, including the heart.
Okay.
And when these pipes are plugged up, like a crut built up inside with this cholesterol, suddenly the blood flow stops, so the heart muscle beyond that will either become weak or actually die, that making the heart very weak. So to prevent it, or if there's a risk of that happening, that's when we do surgery on coronary artery disease.
Okay, all right. So you actually go in because this cholesterol, or it's like fat.
Yes.
Yeah. This fat kind of clogs up the arteries of the heart.
That's correct.
And the blood's not flowing in there to supply oxygen or whatever the nutrients that we need for the heart muscle to keep pumping along.
That's correct.
You actually go in and either clear it out, well, you actually replace them, right?
Yeah, what as surgeons we do is, the circulation to the heart is like plumbing. There is blood coming from, maybe I can show a little bit on this model of the heart.
Yeah.
This is heart has 4 chambers. This is the left lower chamber. That is the pumping chamber of the heart.
Right.
And I'll separate it. This chamber is a pumping chamber. When the blood is pumped out of this aorta, that supplies blood to the entire body.
Right.
What heart does is, before it feeds the entire body, feeds itself through arteries that come off that main aorta, and those are called coronary arteries. These red arteries that are shown here.
Right.
Now, if the blood flow in those arteries is what keeps the heart alive by providing the oxygen.
Right.
They're like plumbing.
Yeah, you don't have to put it back. That's okay.
If the cholesterol slowly builds up and reaches a point where the tube is plugged up, like plumbing that is in a clot built up in that.
Right.
Now, there are two ways of addressing that. When it reaches a point that medicine is no longer effective, is either opening up with a balloon or stent. That's usually done by the cardiologist. If that cannot be done, or that fails, or they have a very dangerous type of blockage, then surgeons come into play. What we do is we lay new plumbing in the area where these arteries are blocked.
Right.
We take the veins from the leg and an artery behind the breastbone. We hook up one end of that to this aorta, other end onto this artery beyond the blockage.
Right.
So now, in effect, what we're doing is blood is going through the main artery and bypassing the blockage and supplying blood into the heart muscle beyond the blockage. That's why it's called coronary artery bypass.
Oh, so it actually bypasses the
Blockage, yes.
Interesting, interesting. Boy, this is very delicate surgery, I'm assuming.
Yes, it is delicate, but people are trained. It's a fairly commonly done operation, so it can be done with a reproducible risk,
Right.
which is today is relatively low compared to the risk of not doing it in a given patient.
Right, right. Now, what's the risk of, what are risk factors of your heart having trouble? I mean, I know the big thing I think about is like smoking, things
That's
like
correct.
that. What are other risk factors that people should think about trying to not do so that they can preserve their heart?
I always tell my patients there are 5 things you need to worry about. First one is genes. Unfortunately, none of us can pick our parents, so we can't do much about that.
True, true.
The remaining 4 factors not only cause disease, but also if you have a genetic propensity, you are predisposed to get the disease, they make it happen sooner. So people have control on the remaining factors. First one is eat right. Second thing is exercise, avoid gaining excess weight. Avoid smoking. And fourth one is go to the doctors, make sure you have periodic checkup. At least you'll know if you have a risk factor or you are at risk of getting this, so you can detect early and address that, modify the risk factors by the medications, delay the onset of the disease substantially. We all get the disease at some point, but it's better to get at 90 rather than at 40.
Okay.
So you can have a long, healthy life.
Right. Is there a certain age that where you start looking for the disease? Like 25, 45, 55, am I good until I'm 70?
Well, if you have no risk factors, either genetic or induced by us, then somewhere around the fourth decade, you need to at least go to the doctors and let them check you out. They generally do a routine physical exam, do a baseline electrocardiogram. These days, routinely they do echocardiogram to see heart function, valves and all that. And they do a stress test. If you pass the stress test and all the other tests are okay, you're pretty sure, it's never 100%, but it's reasonably sure that you're okay.
Okay. You said something I'm going to have to clarify. 4th decade.
Yeah.
Number for me.
Somewhere between 40 to 50
years
is when you begin to worry about it. But if you have risk factors, let's say you have come from a family where the cholesterol is extremely high, there are some families like that, then you may have to think about it much sooner.
Right. Okay. All right then. Now, let's just talk about once you've diagnosed, like you said, you do EKGs, you do stress tests, and the stress test is you're getting on the treadmill doing that little jog or fast walk, and then if you have chest pain, then you may have to see you.
Yeah, they look at symptoms at that time and electrocardiogram. They do a EKG. Sometimes they also do an echo stress. Either way, they look at the electrocardiogram, function of the heart. Do you have any symptoms? Let's say you start running on the treadmill, immediately you start getting chest pain or short of breath. You are 40 years of age, you shouldn't be getting short of breath or chest pain within 2 or 3 minutes. Then there is a problem.
Right.
Then your cardiologist, your internist or the cardiologist will recommend further testing, which usually is a cardiac catheterization.
Now, catheterization, just explain that for a minute. They actually put a wire or a catheter in the vessel, and it goes up to explain that just for a second.
Cardiac catheterization is passing a tube, a skinny tube,
right,
through either the groin or the wrist. They stick a needle into the artery and pass a wire on that. Over the wire, they pass a little tube, thread it all the way into the heart here. And from here, they inject the dye. The dye gets mixed with the blood and goes into these arteries that feed the heart.
Right.
While it's in those arteries, they take pictures.
Oh.
So if the dye usually looks black, and if there's an area, the tube, rather than being smooth, is very ratty or narrow, like apple core, and there's a problem. There's a blockage.
There's a blockage.
There's a built-up cholesterol that's not allowing the dye to fill the artery there.
Right. So the dye doesn't go through smoothly.
Right, yes.
So you can see it on the X-ray.
Yes. Yeah.
Interesting.
And depending on what is the extent, the location, appropriate treatments will be recommended to them.
All righty. Now I know that the heart specialists who are not surgeons, they have what they do. They go in and open up vessels when it's appropriate.
That's correct.
Tell me about cardiac surgery. Just basic stuff. Is it a long surgery? Is it like, is it all day, or, what happens to it? Tell me about this surgery.
Let's say a patient was recommended to see a surgeon by the cardiologist because he found something that requires coronary artery bypass.
Okay.
Generally, the few reasons why they recommend surgery is if the main artery that supplies the heart, which is on the left side, has got a tight blockage. The reason for that is that closes, more than 40 to 50% of the heart muscle dies. Most often patients end up dying. If not, they'll be totally crippled. We don't want that.
Right.
So when they see that, they recommend surgery. Or if you have multiple blockages in multiple arteries and their branches in this artery, they think it's too many areas to fix it with the stents, they send the patients to surgery. Or if you have 2-3 arteries and the heart is already weak,
right,
and they don't want to do that. And in diabetics, you're better off getting surgery than angioplasty in general. Balloon procedure is not as effective long term. So these are situations they send the patients to surgeons to evaluate for surgery. After we do the evaluation, we schedule the operation. Operation is usually, depending on number of bypasses, anywhere between 3 to 6 hours, but it depends on how much work you need to do.
Right.
1 bypass, 2 bypasses, as much as 6-7 bypasses, whatever you need, we do it.
So you can be in the operating room and you're working on someone's heart for 6 hours.
That's possible.
That's possible.
Yes.
All righty, that's good. I like that. You're talented.
Thank you.
Let's just step back just for a second. Now, I want to get an understanding of what this surgery is like. You actually prep the patient, and once the patient is prepped, you actually open the chest.
That's correct. It is a major surgery. There is no question about it. But fortunately, this has been done for 50 years. Right. Most of the wrinkles are ironed out, that we can today pretty much say if the patient is referred to you electively, which means you're not rushing into the operating room because some disaster happened, we can almost 98% of the chance that patients do well, which is not bad compared to the magnitude of the surgery that you have to do. Now, when the patient is sent to the surgeon, we sit down and talk to the patient and the family first. We show them the catheterization films, echocardiogram and all that after we examine and take the history and come to a conclusion, yes, we agree that your doctor, what he sent you here is appropriate. Right. Now, once that is done, we explain to them the surgery, how it is done. You're right, the surgery is done traditionally under general anesthesia. Open the chest in the midline, split the breastbone. There's an artery behind the breastbone on the left side. It's a very precious commodity. We use that for 1 bypass in the front of the heart. This one artery can keep the patient alive 90% of the times, 20 years. If that stays open, works good. So we invariably try to use that. And then part of the team will then do a small cut in the leg, passing a camera to the leg, take enough vein in the leg to use for the other bypasses. Once we have these tubes, the spare parts are now ready. Then we make a decision, is this heart capable of handling if we did the surgery without stopping the heart? Because sometimes it's better not to stop the heart, sometimes it's better to stop the heart. That's a judgment we do. And if we can do the beating heart surgery, we use these tubes and hook up one end onto the aorta and the other end beyond the artery as the heart is beating. But traditionally, what we do is put a tube in the main artery, aorta, another tube in the right upper chamber, and divert the blood from the heart into the heart-lung machine. Heart-lung machine will then clear out the carbon dioxide, add oxygen to that, and pump it back into the aorta through a separate tube.
Okay.
So essentially, what we're doing is taking away the function of the heart and the lungs temporarily. That gives me the luxury of being able to stop the heart, stop the lungs for finite duration, 30, 60, and 100 minutes, depending on whatever you need to do. During that time, heart is still, quiet. It's a lot easier to stitch. We do whatever work needs to be done, and during that time, we give a medicine to the heart that just stops the heart.
Right.
When all the work is done, we let the normal blood go to the heart also. Heart automatically begins to start beating. It's a remarkable organ.
You mean when the blood comes back in,
it starts beating slowly.
Picks back up.
That's right. And only thing is we have to wait till it just recovers some strength. Slowly, as it gets stronger, over the course of 5-10 minutes of it takes to wean the patient from the heart-lung machine, and the heart takes over the work.
Interesting.
And then we take all the tubes out. Now it's good as gold.
Tell me about this heart-lung machine. It sounds fascinating. You actually have a machine that can take blood and take out the bad parts of blood, add oxygen to it, and then feed it back to the body while the heart's taking a rest.
That's right.
That's so fascinating.
The blood drains from the upper chamber of the heart, right upper chamber. It goes into this machine. These are pumps. They pump what blood comes in. It goes through a membrane oxygenator or capillary oxygenator. There are varieties of oxygenators that they're getting more and more sophisticated, smaller. What they do is
so an oxygenator means that it actually adds oxygen to the blood.
One side of it there is an oxygen, other side is blood. There's a layer of membrane that is in between. So the oxygen goes into the blood, and now the blood has more oxygen, just as if your lung added oxygen to the blood.
Right.
Now another pump pumps it back into the main artery that comes out of the heart. So the whole body gets the oxygenated blood. One of the things that we do is we bring the body temperature down a little bit during that time. That way the requirements of oxygen drops a little bit, gives you a little more comfort zone rather than being normal body temperature. And towards the end we'll warm the body temperature back up.
Say that again. You actually cool the body down because a cold body does not use as much oxygen.
That's correct. That's correct.
And then you warm it back up.
That's correct.
All right.
When we begin to say, okay, all the bypass are done, we say, warm the patient.
Right.
Then the same machine has got a heat exchanger that takes and gives back heat. So when we say warm it, they have a water bath or electric that makes the blood warm as it circulates through that.
Right.
So slowly they warm it back to normal temperature. And when the body temperature is normal, heart beats normally.
It just comes back to life.
Comes back to life.
I love this.
Yeah.
I love this. Let's talk about another aspect, the valves of the heart. And sometimes I know as we age, just like anything else, it's working, and it just gets old, and it stops working as well as it did when we were 20.
You're right about that.
Tell me about the valves and how they are situated in the heart and when they would need changing or how they would need changing.
For all the romance of the heart that everybody talks about, heart is a pump.
Right.
It's a bladder made out of muscle and tubes. Its purpose is to drive the blood in one direction all the time.
Right.
Okay? The blood from upper half of the body and lower half of the body comes up into the right upper chamber. Mind you, this blood has gone through the body and the body has extracted all the oxygen nutrients that it needs.
Right.
It comes to the upper chamber, and the upper chamber squeezes the blood into the right lower chamber through this valve. This is called tricuspid valve because it's got three leaflets.
A tricuspid.
Yeah. And so it pumps into the right lower chamber called the right ventricle.
Right.
When this pumps the blood, it goes into this big blue tube that we're into the lungs. This is called pulmonic artery, main pulmonary artery. There's a valve, I don't know if you can see that or not, right there. So when the right lower chamber pumps, blood goes into this artery. When it pumps and begins to relax, the valve shuts. Same thing as tricuspid valve. When the right lower chamber is squeezing, the valve shuts, so the blood does not go back again into the upper chamber.
Right, so it doesn't regurge back.
That's right. The valves are made so the blood goes in one direction only.
Right.
Now the blood goes through the pulmonary artery into the lungs, gets oxygenated, and returns through these veins into the left upper chamber here.
Now it's on the left side
at the left side. That's called left atrium. And when that pumps blood goes in the left lower chamber, that's called the left ventricle. This is the principal chamber in the heart because this is the one that pumps blood to the entire body. Now when this begins to squeeze, this valve between the left upper and lower chamber called mitral valve shuts. So the blood doesn't go back. And the valve that is here, that's going into the main tube, aortic valve, opens up. So the left lower chamber squeezes through the aortic valve, and when it empties out, it begins to relax again to receive more blood. Aortic valve shuts, so the blood doesn't leak back again. This repeats 72 times or more or less depending on your exercise and things like that throughout your life. Phenomenal organ. Unlike most other organs, this cannot stop. It just keeps working.
That's right. Don't let the heart stop.
That's right.
Please don't let it stop.
That's right. So the purpose of the valves is to keep the blood going in one direction.
Interesting.
Now, if the valve fails, blood can leak, or if the valve narrows, the heart has to struggle to pump through a tinier hole, and ultimately it fails.
Right.
So when it leaks, it's called regurgitation. You must have heard those words.
Right.
When it is tight, blocked, it's called stenosis, narrowing.
Narrowing.
Both are problems that you need to address.
Interesting. All righty. Well, at times you would have to change the valve, I understand. And which valve? I know that, let's just talk about the aortic valve. That's the last valve before the heart actually pumps it into the body or into the system.
Correct.
Let's talk about one of the valves and how we would change that valve.
Okay. Now, the two principal valves that we have to most often address is left side valves, anyway, mitral and aortic. Now, the aortic valve, which is between the left lower chamber and the main tube, aorta, with age, it has to open and close several times. It gets hardened.
Right.
It gets less and less mobile. Right. It doesn't open and close that well. So as you get older, it gets narrow. Since they don't open, the hole itself gets narrower and narrower. There are a couple of ways of dealing with that. Traditionally, what we have done is remove that and stitch a new valve. Depending on the age of the patient, we either use a tissue valve, one of these things that I'm showing here, or mechanical valves, which is made out of, we call it metal, but it's not really metal, it's an artificial material. This is again done as a heart operation. Open the chest, put them on a heart lung machine, stop the heart. Once the heart is stopped, open the aorta, cut out the valve, and stitch this new valve, either the tissue valve or a mechanical valve, in the place of the original valve. And then sew this aorta back together. When you restart the valve, now the valve opens and closes normally. It's a mechanical or tissue valve. They're two different kinds depending on the age and requirements.
Interesting. So those valves actually, once they're in, they just work as though they were normal valves.
Yeah.
Interesting.
But they're still man-made valves, so they're not as efficient, as good as God's valves.
Right.
But this is the next best thing we have. The best thing is to prevent these things as much as possible, but some of them are not preventable. So when they come to that point, we'll have to replace those valves.
Wow.
Now the aortic valve, Omar, there's a new thing coming up. Elderly patients these days, once upon a time when the patients are quite elderly, we felt that they're too old, they may not be able to tolerate the big operation like that.
Right.
And nowadays we're doing these valves deploying on a catheter. You don't have to even go through an operation. Just like the catheterization, they load the valve on a catheter, go through the aorta and deploy it and just stretch the native valve, and it anchors there and it works. A lot less stress on these elderly, frail patients. This can also be done through the tip of the heart. So there are a couple of different ways you can now help even elderly patients who probably can't handle regular operation.
So what you're talking about is that you access an artery, I'm assuming a large artery, and you put a catheter up that has the valve on the end of it.
That's correct.
Push it up into place.
That's correct.
And then kind of open it up and let it,
That's
and
correct.
It does its thing.
It just takes few seconds to stretch it open, and it just stays anchored. You're done. So there's a lot less stress on the patient. So this is being offered at multiple institutions across the country now, something for elderly patients to think about.
Interesting. Well, I know that we have several other things that we wanted to cover, like pacemakers and all of the fancy devices that you put in as well, but we just don't have time, so we'll have to bring you back. Dr. Karanam, thank you very much for taking time, and thank you. We'll have to have you back again.
It's my pleasure, Omar.
Thank you very much. Well, this show really went fast. We're going to have to skip our Let's Talk. And in closing, remember, sharing and caring, www.medmoments.com, and email me. Give me an email, guys. Also, tweet me @medmoments. Never institute any change in your medical therapy before you consult your physician. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all. Dr. Karanam, thank you again for coming.